Beyond the Scope. I am visiting with Miss Brown today. She's a 40-year-old right-handed woman who came today with various complaints, and I'm just going to recap those. This is the second visit. She's kindly agreed to be part of the video series in our goal, our mission to decrease information asymmetry between physician and patients. And so the recap, and then I'll do an exam, but essentially she has a history of being treated at Dornbecker Children's Hospital for scoliosis in the past. She's undergone no surgery. Has significant past medical history of tethered cord from her mother's side, and has a long-standing history of low back pain, and over the last couple of years she's had progressive neck pain. So far so good?
Yep.
And then over the last several months you've had progressive arm pain, predominantly on the right side.
Correct.
But some left-handed symptoms as well.
Yes.
And you were evaluated prior to our visit today, including a cervical MRI, which we'll review later, and EMG nerve conduction studies to evaluate for carpal tunnel syndrome.
Correct.
And you find that at times you'll be awakened at night because of pain in the hands. It'll tend to make you want to shake them. And that you do have pain that goes up the arm on the right side. And that you've noticed weakness in your right hand.
Yeah, I drop things all the time.
Okay. And so the cervical MRI recap before we look at it is it showed some mild narrowing on the left at C4-5 and some mild narrowing on the right at C6-7, but fairly underwhelming. It did show some degenerative disc disease at C6-7, and we discussed that at some point if your neck pain was so severe, that is, it didn't respond to a carpal tunnel release, that we could further evaluate it perhaps with a study called the Diagnostic Provocative Cervical Discogram, but we're not really entertaining that at this point. Also in your history you described that you get a sensation of kind of an ache down your right leg, kind of down the side of the calf and goes down to the ankle.
Yeah, it goes into the ankle, kind of almost Charlie horse.
Charlie horse, okay. And you described your neck pain as moderate to severe. And it can be all day long.
Oh yeah.
There's not one particular activity that makes it worse.
Just my life.
Your life makes it worse. And the exam findings that were positive were that she had numbness in the right arm and hand, and she had weakness in the right hand. She's right-handed, as I said earlier, and on the use of a dynamometer that can quantitate, that is, to give us a number of the strength, we found that her left hand was much stronger than her right hand, where normally the right hand should be at least a little stronger than the left hand. And pertinent negatives that I found on the exam were what we call a Sperling sign, or Sperling exam, where I have her bend her neck back and over to the side, and what that can do is close the hole where the nerve comes out if there's significant narrowing in the neck. And if there is, it can elicit symptoms down the arm, and she did not have a Sperling sign. And her reflexes were normal in the upper extremities. And so really the only thing that we're going to capture on the exam at this point will be the Tinel's, that is where I tap a hammer on her wrist. It causes exquisite pain in her case, into the hand, predominantly on the right and to a lesser degree on the left side. And the rest of the exam findings, like I said, were unremarkable other than the numbness. And then we've already discussed carpal tunnel release, doing an endoscopic carpal tunnel release, and we're going to have this as part of our video today that will be filmed, and then we'll have our post-operative care as well and see what the results are.
All right.
Okay? And so the way we check for the motor strength, as I described, using this dynamometer, and it allows us to quantitate, that is, show us how many pounds of strength she has when she squeezes it. And so typically what I'll do is have the patient squeeze on the hand that is less affected. And so I'm going to have her do it on the left side first and squeeze that as hard as you can. And that's similar to what she had last time. We had about almost 80. You can see right there. And then we're going to have her squeeze that on the right hand. And it's similar to the exam. It's just about above 55. And so we would expect certainly that the right hand should be at least 80 or maybe even a little stronger. And then also on the exam findings here that we found, I'm sorry to torture you on this again, is where I tap her wrist, and that the median nerve courses right through here, and that causes pain in the hand. And did it do it again? Okay, so I won't keep torturing you. I'm on your side.
Thanks.
And then on the left side as well. And then when I compared the sensation of light touch in her arm, she described having less on the left side, or on the right side rather than the left side, and that's still the case. Okay? Anything that I've omitted or not been accurate on our history so far?
No, don't think so.
Okay, and so we're also going to film her surgery.
All right.
So that's it. Thanks. We're now using the Aggie endoscopic carpal device. We're inserting it into the wrist incision. Through the scope, you can see this yellowish tissue that is the transverse carpal ligament with some synovium, which I've swept away using different dilators and then a dissector. The scope is then being advanced to the distal or end of the ligament. I'm able to palpate through the hand. You can see how I can push it down from above. I engage the scalpel, I withdraw the scope, and I'm cutting the ligament. And then I re-advance the scope, and any remaining fibers I divide. So this, using endoscopic technique, I'm cutting the ligament from the inside out instead of from the outside in, allowing for much smaller incision and quicker healing. The nerve is out of view with the scope here, but it would be just to the right side, kept out of the endoscope channel. You can see some fatty tissue herniating or going into the defect that I've created, making sure I cut any remaining fibers. The tourniquet, which was inflated initially, will be deflated with the scope in place, and then the wound is irrigated and closed with a 5-0 subcuticular suture and steri strips.
Well, tell me about the recovery. How was the recovery?
I immediately felt relief in my hand. It went through its stages of different areas that hurt as it's healing. I have felt different stages of sensation of things coming back and things that I'm hoping will continue to come back.
Okay.
And I am really happy to say, and very surprised to say, that I felt immediate relief in my neck.
Did you?
I did, and that's why I started this entire adventure 2 years ago. It was because of neck pain. And then my arms went crazy in the meanwhile.
Let's take a look at your incision that we did about 3 weeks ago. And her pain in her hand at night got better right away. Her numbness is improving slowly, and we're hopeful it'll continue to improve over the ensuing weeks to months. And I understand we're planning on doing Monday the left hand.
Yeah.
Excellent.
Yeah.